Hello, everyone, and welcome to the FDA'S Computational Science Symposium Safety Analytics Workshop. This is a recording, so unfortunately we don't have a way to interact, but if you have any questions, certainly you can contact me after listening to the recording. So this particular workshop is on planning and interpreting safety analyses for integrated summaries. Last year, we conducted a workshop for individual studies. So this is somewhat of part two of a safety analyses workshop. Now, it's not critical that you listened to the previous workshop. This can stand alone as its own educational workshop, but certainly I would encourage you to listen to that previous recording available on the FDA'S deliverables website. So first, to introduce myself, I am a statistician. I have been working at Lilly since 1989, and I have been part of a safety analytics group at Lilly since 2011. And as part of my role, I consult with compound teams on their safety analysis planning. So the safety analyses for integrated data is part of my day job. So it is something I have been doing for a lot of years. And even before the safety analytics group, I have been working primarily with safety. So I feel like I have had a heavy emphasis on safety for my entire career. I also co-lead the FDA'S Safety Analytics Working Group. I used to co-lead what was called the Standard Analyses and Code Sharing Working Group, and has been part of that since 2012. However, the working groups have been restructured, and now there is a brand new working group called Safety Analytics, and I co-lead that. And the interim co-lead with me is Greg Ball from Merck, and so he's just starting as a co-lead for this group. So the content for this workshop are the published FDA'S white papers. So I would like to acknowledge all the co-authors and reviewers of the FDA'S white papers. So all of that work and all of that content that's been developed since 2012 really is the source for the information in this workshop. I'd also like to acknowledge Nee Beasley. She is our FDA liaison for our white papers. And I'd also like to recognize Shyamitana Balasundram, who is a peer reviewer for these slides. So as a disclaimer, the content of the white papers, and therefore the content of this workshop, should not be interpreted as an expectation or a requirement from regulators. So while the FDA'S white papers are part of the FDA-FDA'S collaboration, and FDA members have been involved, it should not be interpreted as an FDA expectation or requirement. So the agenda is that I'll start with some background. We'll go through some definitions, and then the rest of the workshop, or the majority of the workshop, will be about the integrated analyses themselves and recommendations for how to conduct these integrated analyses. And we'll talk mostly about adverse events and a little bit about labs. And then there are a few slides on some miscellaneous topics. And this workshop will be recorded. It will be publicly available. So we do encourage you to share the recording with your colleagues. And this would be your cross-functional colleagues. So this is intended to be for a cross-functional audience. So statisticians, medical, writers, regulatory associates, right? So it really is intended for a broad audience. And we encourage you to share this with your cross-functional team. So background for having a workshop, and also its background for why we even had the FDA'S white papers, is there are aspects of in predominant practice that can be improved, right? So there's a lot of things that we just do by habit, and some of the things we do by habit, are just fine, but other things certainly need to be improved. And this is particularly true for integrated analyses. It's also, we have examples for individual studies as well, but this is particularly true for integrated analysis. And it's really difficult to improve predominant practice, right? It's always difficult to change what everybody does or what you have done for years. And in order to be successful at changing predominant practice, we do need to raise the bar a bit on some of the safety analytics education and have our cross-functional teams be well educated on some of these educational aspects. So it is a very common pitfall, assuming, that what you have been doing in the past or what everybody else is doing is actually the best way to go forward, right? It is time to improve some of our practices. So we are aware of some poor practices, and we want to change those. We also know there's been an evolution in some other areas. For example, in the past, it may have been just fine to have a submission be full of static tables. And now there really is more and more of an expectation we need to have more figures. It's starting to become much more expected. And so we do need to move away from tables to figures. So that is an example of something we do want to change as part of predominant practice. So as already mentioned, our primary resources for this content does come from the published FDA'S white paper. So there's an adverse event white paper published in 2017. And there were some labs, vitals, ECG white papers that were published in 2013 and 2015. And other resources include an FDA 2010 clinical review template that was also used as a source for the white papers and also mentioned a few times in this workshop. So that is a very useful resource. We also have other publications that we've used as resources. There's a particular book chapter that goes into more detail about how to combine data from multiple studies and some of the general methods. And so there's a reference for that. And also there has been a FDA'S 2019 workshop on individual studies. So that is another thing to watch if you haven't already participated in that. This slide does include additional resources. There are very good SIAMS guidance documents that are very relevant for integrated analyses and additional manuscripts that are very relevant for integrated analyses. So for those involved in integrated analysis planning or in interpretation, I really consider a lot of these things a must read. If you are involved in planning and interpretation, you really do need to educate yourself on some very key meta-analytical methods and some just key pooling concepts. So it's really important to come to the table with the proper training or the proper education. And so hopefully these resources will prepare you in your role for being a participant in integrated analysis planning. So one convention that facilitates discussion, and this is something we do see a lot. A lot of times when you're working within a team at a sponsor and you're working within a team, a lot of times someone might say, well, the FDA thinks this, or the EMA thinks that, or the PMDA thinks this. And it's never clear on whether or not that person is referring to a regulatory guidance in which you can consider that a broad opinion from a particular regulator or agency, or is it just a personal experience or a personal interaction that they may have had on their particular study or submission? So it's really important to know the difference, right? So what happens a lot is if there's been one interaction, right? So it's a common pitfall that people will assume that if they had one interaction with one regulatory viewer, that it must be a commonly held opinion across the agency. And that's not true for regulatory agencies. It's also, not true within sponsor companies. People do have various opinions. And there are so many, especially with safety analysis planning, there are all sorts of differing opinions on how analyses should be done or how data should be handled. So it's really helpful when you're in conversations within your team that you distinguish between these two. So when somebody says the FDA thinks or the EMA thinks, that should be reserved for if there's a documented guidance, right? And if it's not the case, it's really helpful in your conversations to say, Well, our medical reviewer asked us for this, or in our interaction, we believe they think this, right? So this was really helpful because it really does help just facilitate team conversations when people know the difference between the two. So let's start getting into some definitions. So a lot of our integrated analyses are all about trying to help determine what's an adverse drug reaction. So let's start with the definition for adverse drug reaction. And this definition is in the FDA'S adverse event white paper and with references included. And it is an undesirable effect reasonably likely to be caused by a study drug. And it may occur as part of the pharmacologic action or the study drug, or may just be unpredictable in its occurrence. But it really is all about having the data you need to decide what is reasonably likely to be caused by a study drug. So the methods to determine which events or changes in labs, vitals, or ECGs, which events are adverse drug reactions, there are a lot of factors that go into this. And some of them are related to statistical analyses, but some of them go beyond that. There's very much a medical judgment component to determining ADRs. But our statistical analyses, when they're done well, absolutely will help in this determination. And actually, for the more common events, it's a key part of helping a sponsor decide or a regulator help decide what's an ADR of the drug. So the factors, and there's a lot of references for this too. There's I think there's a science guideline that really is helpful to understand the thought process behind deciding what's an ADR or not, and that is in the references. And these factors include how strong your evidence is for an imbalance with your drug versus placebo. This can be done via p-values or confidence intervals. And then magnitude of effect of your data, like odds ratio, risk difference, how big your effect is. Is it 2 times? Is it 3 times occur more often? Dose effect is also very important. If you have an event and there's a dose relationship, that's pretty strong evidence that it could be reasonably likely caused by the drug. Now, getting into the more medical parts of the decision-making process, biological plausibility is key. If there's biological plausibility and there's data to support an imbalance, that's very strong evidence for causality. It's less clear if you don't have biological plausibility. It maybe is a little more difficult to make a decision on whether it's an ADR. So biological plausibility is certainly key to the decision-making process. So clinical relevance of any individual case. There could be some rare events, and a lot of the time the decision is all about how impressive those cases are, or how convincing those cases are. Are there alternative ways in which that event could have occurred? Or is there any re-challenge or de-challenge information, right? Even just a couple cases with some de-challenge or re-challenge information could be all you need to decide that something is an ADR. How severe the event is, right? So you'll see this if you read the science guideline, right? There's this idea of a threshold, right? So the more severe or serious the event is, you might have a different threshold on whether or not to consider it an ADR. You just might have a little lower level of confidence if it's more serious. Even if you're not completely confident, if it's just leaning in that direction, you might make something an ADR if it's serious. So the severity event does go into the equation in the thought process. How consistent the findings are across studies, right? So something that is consistent across studies is more convincing that it should be an ADR, and how consistent it is across other related events. So that's also a factor. And then it also matters what's going on with other drugs in the class and what has been seen in the class. So all of these things are important factors in determining ADRs. So I'm going to cover a couple common pitfalls. So when you are creating your integrated analysis plan, which is designed to help determine which events are ADRs, one common pitfall is believing that you should be conservative in your methods, right? That thinking that choosing definitions or methods that are the most conservative or includes the greatest number of events is the best way to go. And we hear this all the time, right? It's safety. We have to be conservative. So one very common misperception is that just because you might be more conservative from a total count perspective, when you talk about imbalances between treatment and placebo, including more events or being more conservative may not at all be conservative when you're looking for imbalances. In fact, sometimes being overly inclusive can actually underestimate your relative risk or your risk versus placebo. So this is a very important thing that it's not well understood when people are planning analyses, that you have to think that the key part of ADR decision making is a lot about the imbalance with placebo, and being conservative from a total count perspective might actually not be conservative at all from a relative risk or risk difference perspective. So that's a very important concept to know, that over inclusion might actually not be helping you find your ADRs. So some other definitions that's helpful for conversations. These definitions really facilitate conversation for groups who are talking about integrated analyses. It is a distinction between your purpose of your analysis. You really need to understand the purpose of your analysis. And our standard safety signal detection package is about signal detection. So these are analyses and displays used to determine which events or changes in labs vital ECGs require further evaluation to decide whether or not it is an ADR. Now, signal clarification could be additional analyses that might be needed to help decide whether it's an ADR or not. And these are things that might go beyond the standard initial package. So there could be additional things needed to help decide. Then signal characterization is usually done after you do decide what your ADRs are. Once you know what events are reasonably likely caused by the drug, you might want to characterize them. Do they occur early? Do they occur late? Are they more mild? Do they last long? How long do they last? Is it persistent? Is it transient, right? So those are examples of signal characterization. And then signal communication is what kind of like labels or other ways of communicating ADRs, right? So once you know your ADRs, you then want to communicate them and communicate them in the best way you can. And not always, but oftentimes we might need additional summaries that are intended for communication purposes. So this slide is just kind of going through the flow from signal detection through signal characterization or clarification through communication. So some tables, figures, and listings are used for multiple purposes, but some are meant for a particular purpose, right? So there are cases where a particular regional label might want to display the ADRs a certain way, and it's okay that something like that is created for that label without then trying to make it be part of your signal detection package, right? So it is a common pitfall to not necessarily understand the purpose of an analysis and where it fits. And sometimes not understanding that creates confusion, right? So there is a tendency for people to put everything that they might want for characterization or communication, that they want to put all of that in the plans for signal detection, and that's not necessary. That sometimes creates an unnecessary volume of work, and then of course, when you have unnecessary volume of work, that takes time away from the things that really matter. So it is really helpful to understand the purpose and where it fits in the flow, so you don't overburden your team with unnecessary work. So other definitions that come up in the integrated context is a program safety analysis plan. So a program safety analysis plan is a compound level planning document, and it can also inform individual study planning, but it informs integrated planning as well. Now, this has been published. The idea of a PSAP, a Program Safety Analysis Plan, has been published as a cross-industry recommendation. However, it's not necessarily fully implemented, and the nomenclature is not necessarily consistent across companies yet. So sometimes companies will not create a PSAP, but will create an integrated statistical analysis plan, or an ISAP. There's also some talk about another document called aggregate statistical analysis plan. So that's another idea that has been discussed in a cross-industry setting. So the current state is the industry isn't very consistent on what we call these integrated planning documents. We have different names for the same things, or they have slightly different purposes. So while I do think we want the industry to start moving toward a consistent nomenclature on this, or a consistent process, it's not really as important as just having a integrated plan, right? So it's important that you just have an integrated plan, and that plan occurs early enough. And so that's the important thing. And I do think sometimes, I think people or sponsors are getting better at this, but we certainly do have examples where maybe this planning hasn't occurred as early as one might want them to occur. So it's just important to have integrated planning in place and for it to occur early. So that is distinct from a statistical analysis plan that is meant to describe the planned analyses for an individual study. So other definitions that will come up in this workshop is a static display versus an interactive display versus an interactive tool. And these are not necessarily, commonly used words to describe what these different, this differentiation. But I'm going to use these words, and maybe there are better words to describe these things. But for purposes of discussion, we'll use these definitions. So static display is a table figure listing that's created without any interactive features, right? It's something that's kind of viewed on a page, right? And this is what most of us are doing today when we create our study reports and submissions. We create tables and figures and listings that can fit on a page. So even though we may not be printing these pages so much any longer, they're on digitized paper, right? They're still fitting on a PDF. So an interactive display would be a table, figure, or listing that allows some point-and-click technology to do things like zoom in, or a scroll bar, or hover over a data point so you can see more information. And it might also allow you to control some of information in what you might want to display. You might give the user a choice between an odds ratio, a risk ratio, or risk difference, right? If you're in the static world, you usually pick one, right? And sometimes that's of quite the debate, right? So one way to get past this debate is actually create an interactive display, allow the user to actually choose among a predefined set of statistics. Now that is different than an interactive tool that actually goes beyond that, where it's point-and-click technology, where you can move from one display to another. You could actually choose certain things and have a reanalysis, behind the scenes, actually have software behind the scenes to conduct a reanalysis. Or you might be able to pick on a event that tells you which patients have that event, and then be able to click on that patient and be able to go see the individual patient data, either through a listing or a graphical patient profile. So interactive tools are great, and certainly there's a lot of evolution in tool development. So these are additional definitions to be aware of. Another definition that comes up for integrated analyses. This is not as key for individual studies, but for integrated analyses, it's really important to understand what heterogeneity means, right? So heterogeneity means that you have differences in treatment effects across your studies, right? And it's treatment effects, which is the key word here. So you might have two different studies that have very different inclusion-exclusion criteria, so very different populations. So the study data could be different, and however, between studies, but maybe the treatment effect, your difference between drug and placebo, can still very well be the same. across your studies. So heterogeneity is when it's homogeneous when your treatment effect is consistent across your studies, and you have heterogeneity when that treatment effect is different across studies. Okay, another definition that comes up for individual studies too, but maybe more important for integrated analyses, is the concept of an analysis set, right? So this is not necessarily consistent nomenclature either. A lot of times people will just say pooled set or have different language, but we can think of an analysis set as just a broad term used to define a set of definitions, right? So what is the population that's going into this analysis set? What are the treatments that are going in? How are you handling the time periods? How are you defining baseline? How are you defining post-baseline? And then what comparisons are you making? So all of these together can then define in a particular analysis set, so that when you're writing up results in a study report or in a submission document, you will have different analysis sets, and these analysis sets can be defined and then referred to in your writing. So one common pitfall when you talk about integrated analysis set, it is almost always underestimated on how much time it takes to really think through all the issues on what integrated analysis sets you should create for purpose of ADR decision making and for purposes of submission and for purpose of labeling. It really does take a lot of time. Maybe if you have a simple clinical plan and have very simple study designs and you have studies that all were designed in the same way, maybe it is not so bad and it's somewhat simple. But more often than not, this can be a very complicated discussion and a lot of different ways in which people might think through the scenarios and the data. So this usually does take a lot of time. And one of the key things when making integrated analysis sets is that you create them in a manner that avoids confounding by study and treatment, and also allows for meta-analytical methods, adjusting for study. So we're going to talk about these terms right now. So these are very key terms when you talk about integrated analysis sets. You got to understand what confounding means and understand that how key stratification by study is. So let's start with confounding. And I'm going to talk about it in the context just of an example, right? So here's an example. You have two studies. One study has new drug and placebo, and another study has your new drug and an active control, right? So let's say somebody says, I want to pool study one. Let's make an integrated analysis set that puts these two studies together. And let's just add up the little ends and big ends. We refer to that as just crude pooling. Just add up the little ends and big ends, and let's make those percents, and let's create an integrated analysis set. So in this example, it is confounded, right? So treatment and study are completely confounded, right? So any differences you see or lack of differences you see, you have no idea if that's because of treatment or if that's because of study. Right. So in this example, study one, you have they're the same. New drug and placebo are the same. Study two, new drug and your active control are the same. Right. But when you crudely pool the data, it gives the appearance that placebo's lowest, then your new drug, and then active control's the worst. Right. Active control has the worst incident for this particular event. Right. And that is misleading. Right. As you can see, that would be misleading because the individual study results show equality, right? And when you crudely pool the data, it provides a completely misleading result. So those differences are due to study, not treatment. And that's what confounding is. 20 years ago or so, like I said, I've been working on safety, for my entire career, which has been over 30 years. Early in my career, it was actually quite a challenge, right? This was commonly requested or commonly done where we had confounding of treatment and study. And I think as an industry, we have evolved away from this, right? We have done a really good job. I don't think we see very many examples where treatment and study are completely confounded. So we've improved beyond that. However, where I don't see any improvement and we still have challenges is when there's confounding by treatment dose in study. And I don't know why people don't understand that these are the same issues, right? It's the same issues, and why we don't pool active control studies and placebo-controlled studies, right? So here's an example where one study has placebo low dose and middle dose, and the second study has placebo middle dose and high dose. And again, if you just crudely pool the data, you're going to be completely misled that the differences you see are due to study, not dose, right? And this actually is more common. We still see examples of this. And this is one part of predominant practice that we do want to change. We want to avoid confounding of treatment dose and study. So this is an example where the differences are due to study. So if you just saw the bottom row, you're going to completely be misled and think there's a dose relationship when there's absolutely no dose relationship at all. So knowing and understanding confounding is very key to planning integrated analyses. So very common pitfall, not recognizing that confounding issues with dose are very similar to the confounding issues between placebo and active controlled trials. So another concept to be familiar with for integrated analysis planning is Simpson's paradox. So even if you are smart enough to know that I'm going to avoid confounding, so you can completely avoid confounding. But if you simply crudely pool the data, you can still be misled, right? So understanding Simpson's paradox is also key. Again, we'll show it through an example. So in this example, all three studies have the same two treatments, a placebo and a treatment arm. So we are avoiding confounding, which is good. But what you'll see in this example, that all three studies show an increased risk with treatment versus placebo. So all three studies are showing that this event could be reasonably caused by the drug. There's an increased risk with all three studies, and it's very consistent. But if you crudely pool the data and you only see the bottom row, it shows no difference. The percentages are almost identical, and the odds ratio is actually less than 1. So this is an example of Simpson's paradox, where the individual studies show one thing, but when you pull it together, it shows another thing. So this is where homogeneity, right, does not equal collapsibility, right? So these are homogeneous results, right? So it's very consistent across the three studies, but that does not mean you can simply collapse the data. So a very key topic that anyone who's this is covered in a lot of statistics courses, right? Homogeneity does not equal collapsibility. So that's a very key thing to know. So what do you do, right? So the important thing is that you stratify by study. You need to use a meta-analytical method, right? So a meta-analysis is a statistical analysis of a collection of studies. And we do need to use meta-analytical methods when combining results from clinical studies. So it is a very common pitfall that some people believe that the term meta-analysis is really meant for when you're combining data from different studies across the literature. Not everybody understands that when you're combining different studies from a clinical trial program, that is also a meta-analysis. And that is a meta-analysis, and you need to use meta-analytical methods. All right, so how do we fix this problem of how do we avoid Simpson's paradox, right? You use a meta-analytical method, and that is done through stratification. Use a method that stratifies by study, right? So in this case, you think of it, a meta-analytical method basically means you look at your individual study data first, right? So you look at the odds ratios for each study, and then take some type of average across those odds ratios, as opposed to adding up your little n and big N's first, and then taking that odds ratio. So it's just an order of when you process the data. So stratification by study means you're first looking at your metric within study, and then taking some type of average of that metric. And so that is the concept of stratification, and it's very important for our integrated analyses. So in our FUSE white papers, for example, the adverse event white paper, but also the lab's white paper as well, our FUSE collaboration is recommending what's called the study size adjusted percentage. So in other words, stop creating those crudely pooled percentages, but instead create a study size adjusted percentage. And then this is a way to stratify the data. So there is more information in the FUSE white paper. A colleague of mine created an educational video. I think it's only 10 minutes or so. So it's a very nice educational video that was created in 2016 that is really helpful to listen to understand more about what a study size adjusted percentage is. Now, there are some scenarios where it may not be required, if all the randomization ratios are the same. And there are cases where it's not necessary to create a study size adjusted percentage, but some people might think, we might just want to make this a habit so that we're never, in a situation where we maybe should have used it and didn't use it. So it is something we are trying to impact predominant practice to do better about using a meta-analytical approach for our percentages. So in summary, when it comes to integrated methods, right, avoid confounding and stratify by study. And it is a common pitfall to say, it's okay to crudely pool the data. It's okay that we don't worry about confounding or worry about stratification, as long as we don't have inferential statistics, right? If we avoid having inferential statistics, it's okay if we confound our data or not stratify our data. I hope you can see from those examples that that is simply not true, right? So crudely pooling your data, getting percentages, whether you have inferential statistics or not, can completely mislead you, right? It is not the case where it's okay to not do these things if you just simply don't put inferential statistics on the table. So let's go through some common integrated analysis sets. Every clinical program is different, and there are obviously always unique features to every clinical program, which is why it always takes a lot of time to think through these. But let's go through some common integrated analysis sets. If you are lucky enough to have your large placebo-controlled studies include the same doses, maybe your large placebo-controlled studies all have the same low dose and high dose in a placebo. Right? If that's the case, you will likely have a multi-dose placebo-controlled integrated analysis set in which you will include the studies in which all, these three treatment arms are included. So take all studies that have the low dose, high dose, and placebo, and the population might be patients treated with at least one dose of study drug. You have your three treatment arms. You define a time period, and then you compare all three treatments. Right? So this could be a very common integrated analysis set. Now, one common pitfall we see is that when people do decide on what their integrated analysis set should be, some people believe that it matters whether or not a study is a phase 2 study or a phase 3 study. In our opinion, it does not matter whether it's phase 2 or 3. What matters is the design. Right? Just look at the design across your entire clinical program and decide which studies are appropriately to be pooled. Now, sometimes it turns out that your phase 2 study was done slightly different or had different doses, right? And it just might turn out that way. And if it turns out that way, then of course this particular common integrated analysis set may not have your phase 2 study. It might just have your phase 3 studies. But it's because these studies had the same doses, and that makes them more poolable, right, or more combinable. It is not because they were phase 3 or phase 2. So the assignment of phase 2 or 3 is really not important. What's important is the design of the study. Another common integrated analysis set is just a simple all placebo-controlled studies. In this case, it would be any study that has a placebo and the treatment under study. Right? And your comparisons would be just study drug and placebo. In this case, it's more often where the dose arms are pooled. And when you pool dose arms in this case versus placebo, you are avoiding confounding and can stratify by study. You define your time period, and then you compare study drug with placebo. And you might have a similar one. You might have one of these where it's the indication under study, or you might, and then quite commonly you'll have another one of these integrated analysis sets that have all indications pooled. And then this becomes a very powerful placebo-controlled analysis set that's looking for signals that might deserve further scrutiny for AAR determination. So it's a very powerful placebo-controlled data. It's not a good one to look at dose relationship, right? You'd have to do something different for dose relationship. But pooling all doses, comparing with placebo, stratifying by study, these are very powerful integrated analysis set for signal detection purposes. Okay, other common integrated analysis sets would then be like an all study drug group. So basically a integrated set that includes anyone who has ever taken your study drug, right? I don't care what indication, I don't care what period of a study, I don't care if it's controlled, I don't care if it's uncontrolled, right? It's just a very simple summary of everybody who's ever taken drug. And this purpose of this is finding the more rare events, right? This is a very easy way to look for the more rare events so that your medical group doesn't have to look through a bunch of tables to find, how many patients had a particular event. This is a very easy way to look at how many patients had a particular event. And then if that then warrants further scrutiny and need to look at individual case reviews, then that would likely be the next step. And then a similar integrated analysis set would be that same one. It's everyone who's ever taken drug, but maybe time is handled differently. So it would include, all time while they're taking study drug plus any time after. So we kind of call that, study drug plus any follow-up time. And so this would be a very similar integrated set with a very similar purpose, looking for those rare events in an easier way than looking through a bunch of tables. But this then takes into inclusion any follow-up time as well. Okay, so one note on extension studies: when you're planning integrated analysis sets, and you might have a very complex clinical plan, it's not unusual for some sponsors to have extension studies. So they might have studies that are controlled and then have some of these studies feed into an extension study in which patients will then stay on study drug for a longer period of time. One thing that is extremely helpful that when you have these studies, it's really helpful to just pretend that this extension data is another period of the feeder study or the original study. In fact, just redesign it, like pretend it's just like redesign the study and add that extension study period onto that study. And that just really helps think through how you want to handle that data and how to include that data. So when this data is an extension of previous data, you really don't want to think of it as its own study. You have to think of it as an extension of those other studies. And that is very helpful when you're planning your integrated analysis sets. So the purpose of standard safety analyses is signal detection, right? So safety topics of interest might have separate analysis plans. And usually it's more in the signal detection and clarification. So a lot of our standard safety analyses are designed for signal detection, and it's designed for looking for the unexpected things, right? So something that you've already identified that could be expected or of interest might have its own analysis plan. So it is all about signal detection. And so common pitfalls are a-priori creating analyses for all four types of purposes, right? Detection, clarification, characterization, communication, right? So really you want to start with detection and only do clarification, characterization, communication when needed, right? So a lot of times we mix those up and we end up with a way too high a volume for signal detection. So another thing that we see commonly done is applying what is needed for a safety topic of interest to all of safety, right? So sometimes we hear, well, we need to do this analysis because this is very important for this particular safety topic of interest. Well, if that's important for a particular safety topic of interest, that's great. Go ahead and plan that analysis. But that doesn't mean you need to conduct that analysis for all the other events, right? So understanding the purpose and understanding that what you might do for a safety topic of interest could be just for that safety topic. You don't have to subject all the other events to that type of analysis just because you want it for one particular analysis. And again, we've talked about this several times, applying what's needed for a label to all of safety, and that's unnecessary as well. So you might need something for a particular regional label. Go ahead and plan for it. You should plan for it, but that doesn't mean you need to conduct that same type of analyses for your entire safety package. So here's the list, the adverse events list of what is recommended in the FDA'S AE white paper. The FDA'S AE white paper does focus on the controlled analysis sets and not so much the uncontrolled, but we'll cover uncontrolled a little bit in this workshop. So the controlled analysis sets, you'll see some things that probably look very familiar to you, right? Overview of adverse events, treatment emergent adverse events sorted by PT, treatment emergent adverse events sorted by PT, preferred term within SOC, system organ class, and then TEs sorted by PT within high level term. And that's in blue because that is actually an added display that's recommended for integrated summaries that we don't necessarily recommend for every study report, because most of these things are also done in individual studies. So common TEAEs, usually as a figure, right? So I know some people still make this as a table, but we do recommend a figure. Treatment emergent adverse events by max severity, and AEs leading to study treatment discontinuation, and SAEs. And then another new recommendation for integrated is a consolidated preferred term table. So at the time that you're looking at integrated analyses, you might need additional summaries that consolidate some PTs that are basically the same event, but might have different PTs, and we would need to consolidate those to look for a signal. So for uncontrolled analysis sets, it's a shorter list, right? So overview of AEs, then TEAEs, AEs leading to discontinuation, SAEs, and consolidated PT. So slightly shorter list, and we'll discuss that in a bit. And again, for controlled analysis sets, we recommend the use of the study size adjusted percentage, and uncontrolled could be a percentage or exposure adjusted incidence rates. So we do have shells. These shells are available in the FDA'S AE white paper, so I won't go through in detail here, but it is different, a little different than the individual study shell in that, of course, we are showing we need to use a meta-analytical method, right? So we're not just showing crudely pooled percentages, right? So we would show study adjusted percentages along with the crudely pooled percentage, and also a stratified method of some sort to give you an idea of the imbalance with placebo, the strength of evidence with your imbalance with placebo, and your magnitude of effect. So these include information on that and also include stratification methods. As noted, for the common adverse events, we do like a figure. And here, this figure is in the FDA'S AE white paper, and it just shows both study size adjusted percentages on one part of the graph and risk differences, or it could be odds ratios or risk ratios, but let's say risk differences stratified by study, right? These are stratification methods that you're using behind the scenes, not just a crudely pooled confidence interval and risk difference. So uncontrolled data, it really is just a simple little n big N percent. Exposure adjusted incidence rates will, many people might want those on these shells as well. And you might have a column that shows here's everything that happened while they were taking study drug, and another column that shows here's what happened while they were taking study drug or at any time after taking study drug, right? So this is a simple display to look for the more rare events that prevents the need for medical people to have to go through a bunch of tables, right? So this just answers the question, what has happened at any time while somebody has been on study drug or after. So let's talk about exposure adjusted incidence rates for a bit, right? So exposure adjusted incidence rates are the number of patients, not number of events, but number of patients with an event divided by the total time at risk for the event, right? So this is a key part of the definition. So the time at risk is calculated as the time to first event for those patients who have the event. And then it's the time during the interval in which you are looking for events, right? You take that time of the interval for those who don't experience the event. So that is how to make an exposure-adjusted incidence rate. Sometimes it's referred to as a person time incidence rate. And a very common pitfall is to use the total patient years in the calculation. But this is a key part of this definition, is for those who have an event, you need to stop at the time of the event. Now that is less important for rare events, right? If it's a super rare event, if you use total patient years in the calculation, it's probably going to be close to, if you actually do cut the time off. However, for more common events, this can have a pretty big impact, right? And if you use all time in the calculation, that could be a very inappropriate, or it could be a misleading statistic. Of course, that matters in how it's being used, right? So it all depends on how you're using the data and how to look at it. But if you're using that data to compare with data from other studies or other compounds, it could matter a lot. Like if one compound does one method, your compound does a method, you're trying to compare them. Well, some of these differences could be just difference in methodology, not actually differences between the compounds. So methodology does matter for exposure-adjusted incidence rates. Okay, so this slide, I won't go into a ton of detail, but it does provide the rationale for why these things are recommended as part of your safety standard package. Right, so the overview is really, the main purpose of an overview table is just to have a nice table to put in your submission that gives an overview of your adverse events. It doesn't help you decide at all which events should be adverse drug reactions, but it's a very nice summary for communication purposes in a submission. Now your TEAE table, it is meant to help you with ADR determination, right? This does give you at least some of those factors we talked about. It does give you, how strong your evidence is for an imbalance with placebo and your magnitude of effect. A common TEAE table or figure actually doesn't have much of a purpose, to be honest. If I owned the templates of individual study reports and submission documents, I would get rid of that section altogether, right? We really don't care as much about what events are common. We care more about events that have strong evidence for an imbalance with placebo, right? So if you have a headache, have headache at 20% of patients and placebo is at 20% of patients, why are we even talking about it? Or why do we highlight that, right? So common events really doesn't have a purpose, but it is in our recommendations just because we are unable to change the templates at this time, right? The templates call for this. People are used to it. And maybe in the future, the templates will change and, we don't need to focus on common events. But right now, it doesn't have much of a purpose, but it is expected per our normal template. So we do recommend that at least for now. So TAs by max severity. This one is interesting because I do not think everyone appreciates the rationale for why that is there. And this is covered very well in the FDA clinical review template, the 2010 template. So the idea is by including all the severities, mild, moderate, severe events, and what we do in our normal TA tables, we might miss a signal, right? A signal might get washed out by including the mild, moderate events, and we might be missing a signal for those severe events. So having a summary that just looks at, by severity with a focus on maybe that severe row, so the idea is, am I missing a signal by including all severities? Are there any signals when I just focus on the severe events that would be important to know about and then might require further scrutiny? So this is very key in signal detection. And I think most people, when they look at a max severity table, think it's for characterization, right? Most were mild, right? Most were this. It's to characterize the event, where actually there is this part about signal detection where this is a key analysis that's probably not always understood or appreciated. So adverse events leading to study treatment discontinuation, it also has the same purpose. You're looking for imbalances between treatment and placebo with a focus on some of the more severe events, and same with serious adverse events, looking for imbalances to help decide, what might be an ADR. Right, so I already briefly mentioned this with TEAEs by max severity. It is a common pitfall to not appreciate the role this table has for signal detection. So when there's a summary of this table written up, you should say things like, after reviewing the data and focusing on the severe events, we do not see any additional signals. Or, this event caught our attention, and you might talk about that event. Instead of just saying, well, most were mild, or some, X% were severe, right? Instead of, when this table is interpreted, the write-up should include a mention of its role in signal detection, and that is a common pitfall. Okay, so this is a new table. A table by high-level term is not necessarily part of practice today. And it's not part of recommendations for individual studies, but it is recommended for integrated analyses, that this becomes a little bit more part of predominant practice. And the purpose for this, it does provide a way to address splitting. And the clinical review template does a really nice job explaining, the concerns we might have of oversplitting the data, and also the opposite, maybe the opposite way is by putting too many things together. So both things are a concern, but this high-level table helps with the splitting argument, right? So it does pool a few more events so you could see a signal a little bit more easier than maybe having a lot of the PTs split up into different preferred terms, right? So this gives another chance for the data to show a possible signal by pooling a bit more things. However, it is not a complete answer to splitting, right? So these high-level terms are still subsets of system organ classes, and there still are cases of preferred terms that are essentially the same thing, but they might even be in different system organ classes. So high-level terms do help with addressing the splitting, but it is not a complete answer. There are other things that might need to be addressed when it comes to splitting. And then that gets us to why we recommend a consolidated term table. Again, this is recommended at the integrated stage. We don't think this level of scrutiny is necessary for every individual study. When you have more data, you're at the integrated stage. We think this is the time to address all this potential missing signals because the data split into too many different measured preferred terms, right? So we do think a lot of this is reserved at the time where you have more data at the integrated time frame. So when you have a consolidated term table, this provides another way to address splitting. Sometimes this is called clustering terms. Sometimes they're called medical queries. A lot of people have different names for this, but the idea, different than SMQ, standardized meta queries. This is more about combining terms that are essentially the same thing that might have gone to different meta preferred terms. Other lists, like a standardized meta query, is more about combining terms that are not necessarily identical, but are consistent with a particular medical, high-level, broader medical concept, right? So this is meant to be different than those broader lists that might have a purpose for some safety topics of interest. This is really meant to address the main problem is we have things that are essentially the same thing going to different meta preferred terms. And we don't want to miss a signal because of that. We need to consolidate some of these preferred terms in order to make sure we don't miss a signal. This is one of the hardest things that we're dealing with right now, though, when it comes to implementation. How do you implement this, right? And right now, it's very manual, right? You have medical people who look at these tables and say, hey, I think, these should be combined. And then you might create a little list and create a new analysis. Certainly, there's opportunity for improvement here on how to implement this. And, so hopefully in the future, there are efforts underway to help make this better. The FDA does have an initiative, medical queries, that might help with this. We'll see. The Medra MSS group is at least considering a project that can create, in addition to high-level terms, but have other ways of grouping the data. Sometimes they call them labeling terms, right? So all of these efforts will help this tremendously. So this is important, but it currently is very difficult to implement because it's a very manual process. So hopefully, together as an industry with our regulators, we can improve on how to implement this in a much better way. So adverse event dose relationship. This is also key. This is a key factor, right? When we show that, all the factors used to determine, what events are adverse drug reactions, looking at dose relationship is a key part of that. And usually, not always, usually you can create an integrated analysis set that helps with dose relationship assessments, right? If you're in a situation where you have the same doses across many of your studies, you can create an integrated analysis set that looks at some dose comparisons. If you're not in that situation, right, it gets a little bit more complex, and you might have to get into even more advanced meta-analytical methods. And we sometimes see this. We do have cases where for some compounds, you might need to get to a more advanced method, and I'll just briefly cover it. It's somewhat beyond the scope of this, but I'll briefly cover it so you know that methods exist, right? There are some indirect mixed methods that could be warranted, especially for dose relationship. And it's usually, in this case, it might be done outside of the context of any integrated analysis set. It might just be a standalone analysis. So what does indirect mixed method mean? So here's an example where study 1 has placebo, low dose, and high dose. Study 2 has placebo, low dose. Study 3 has placebo and high dose, right? So study 1 has a direct comparison of low and high dose. Study 2 and 3, you can provide an indirect comparison between low and high dose, right? So one study compares placebo with low, another study compares placebo with high. So these two studies together provides an indirect comparison of low and high dose. So that's the word indirect means. And mixed means you're utilizing both direct and indirect information in order to look at dose relationship. So let's look at this example again. And this was an example too, where I was trying to show how crude pooling can completely mislead you, right? So if you just crudely pool the data, this looks like there's a dose relationship when there really isn't, right? So studies show complete lack of dose relationship, but when you just crudely pool the data, not even consider that the data are coming from two different studies, you can get completely misled. So what indirect and mixed methodology does for you, it does incorporate your study into how you conduct your statistics. So you're pooling estimates, right? So after using this methodology, you would get where placebo, low dose, and middle dose, and high dose are all the same, right? So it provides a way to incorporate that study data. So it leverages, right, that indirect comparison. It's not just comparing low and high dose, like low dose from study, one study and high dose from another study. It actually leverages that placebo data and can leverage that in order to get better estimates for a dose relationship. So just know that method is out there. And if you're in this situation where dose and study are confounded, there are other methods that can be considered. So now let's get into some frequently asked questions, right? So why is the recommended list for uncontrolled data shorter than the controlled data? So again, let's think of purpose. This is why it's important to understand the purpose of your display when you're planning your integrated analyses, right? So a table of common TAEs is not recommended for uncontrolled data. So why would that be, right? So remember, the uncontrolled data is more about looking for rare events, right? It's an easy way to find how many people ever had this event on drug. And when you have more common events, your control data works quite well, and you should be focusing on your control data. But you really need this other additional data to look for the more rare serious things, right? So why have a summary table of common TAEs for uncontrolled data when the main purpose is all about looking for the rare events? So that would be not recommended because it doesn't really have a purpose, right? The other one that you don't see in the recommended list is the max severity table. Again, we talked about the purpose of the max severity table. It's to look to see if you have any, if you missed any signals by looking at all severities. Is there another signal if you just look at the severe events? And this is, again, in the context of an imbalance with placebo. So it doesn't have a signal detection purpose when it comes to uncontrolled data. However, there could be some cases once you do decide your ADRs and part of your characterization, you might say how many are mild, moderate, severe. It might have a purpose there, and you might want to, you might need some of that data for for your ADRs, but it's not like you need, a 100-page table or more of all the severities for all your events for uncontrolled data. You might just need it for certain events, and you probably need a means to get that data, but you don't need to burden your submission, with this very large table when it doesn't have a purpose. Okay, so another frequently asked question is, how, when we show this data of uncontrolled data, we kind of show a column. Here's all the data. We don't show it by dose, right? And so why do we not have dose, right? Because of everything we talked about, because it would be completely confounded. You might have some doses in some studies, but not others, so you could have confounding. And another key concept is understanding is you might also have yet another problem, and that's called channeling bias, right? So a lot of times when it comes to dose, you do need to focus on that initial dose in which people were randomized to. If you start including doses beyond randomization, like they might end up on a dose because they got re-randomized if they responded, or they stepped down because they were having problems, so they decreased their dose. If there's some reason other than the initial randomization, that introduces bias. So the classic design to demonstrate this is the one shown on this slide. You might have low dose and placebo, and then at some point, patients can switch to, might get re-randomized, right? To get re-randomized to stay on low dose or go to high dose. Or it might be a titration study. Maybe everybody starts on low dose, and the people who are tolerating the low dose, are allowed to go to high dose, like a titration type study. So this design is the easiest one to understand what we mean by channeling bias. So as you can see, the only people who would get high dose are those people who tolerate low dose, right? And that group is very different than if patients were randomized to high dose, right? It's a very biased sample on who gets high dose. So if you were to summarize this data, create a placebo, low dose, high dose summary, high dose will almost always look the best. And it's not because high dose is the best, right? It is because only those people who can tolerate the drug even get to the high dose. So that's a very significant bias, a very common pitfall that people want to summarize dose in a very easy, crude way, right? Because it would be easy to look at, but it could be so misleading, right? It's so not even helpful, and it is a common problem. So understanding channeling bias when it comes to dose relation summaries is a very important thing to understand, when you're planning your integrated analyses. So looking at dose relationship across studies is actually very challenging, and you really need, in some cases, very advanced meta-analytical training and methods to be able to do this, right? So it's very key to understand confounding, understand channeling bias when looking at dose relationships. So that's why we don't have dose on this uncontrolled summary, because it's going to fail all those meta-analytical principles in almost all cases. Another frequently asked question is, why do we count the number of patients with events instead of number of events? Well, really, mostly because it's just simpler and it works fine in most cases, right? So the other big challenge we have with counting events is collection, right? There's a lot of variability in how events are collected. So in some cases, each headache might be collected, or maybe it would be collected as intermittent headaches, like one instance of intermittent headaches, right? So because we have this variation in collection, it really complicates the interpretability of the number of events. Now, maybe if collection gets, more consistent. Maybe there's something, more we can do with number of events. That being said, there are cases where counting events, or at least attempts to count events, might be warranted. That we do have classic examples, right? So hypoglycemia in diabetes studies, or infections, maybe for some of our compounds. So some of these are so common that if you count patients and they're treated long enough time, maybe most patients will at some point, get the event. So it's in those cases, maybe it is of more interest on number of events as opposed to how many patients have the event. But for run-of-the-mill safety signal detection, for looking for the unexpected things, we don't think counting events is warranted for signal detection purposes. All right, one debate that almost always comes up is, should we include p-values? So in our FDA'S white papers, we do talk about this, and we have a whole paragraph for you to read about this. We have not necessarily taken a position on this, and we don't think our cross-industry group is going to actually resolve this debate. This debate will probably remain, but there are some key things that we want to share. One is we do think it's helpful to have something, right, whether it's a p-value or a confidence interval, something that helps you assess the strength of evidence for your imbalance, right? So having something we do believe is helpful. And the other key message is, if you do include p-values for safety, I don't think anyone, even the people who like p-values for safety, which, by the way, I am one of those people, right? So for anybody who likes p-values for safety, no one is trying to say these are used for hypothesis testing, right? So they can't be used for hypothesis testing, and most people know that, right? So you have to think of these p-values as just a number between 0 and 1 that gives you an idea of how strong your evidence is for an imbalance with placebo. So they're never used for hypothesis testing, unless, of course, the study is designed for a particular safety outcome. But in almost, most of our cases, we're talking about, studies where that is not the case. So confidence intervals do provide a really nice means for assessing strength of evidence, but it's a little more awkward for ranking. A lot of times you kind of want to view your data on what are the events that have the most strong evidence for an imbalance with placebo, and rank order them that way. And doing that through a confidence interval is a bit more awkward. So p-values do help a little bit for ranking purposes. But the main thing is we do think it's useful to have something that assesses the strength of evidence beyond the eyeball look at just the percentages. So one key thing that I don't think is well understood is that your strength of evidence for an imbalance and your magnitude of effect are not the same, right? So if you didn't have odds ratios, didn't have p-values, didn't have risk differences or any kind of confidence intervals, if all you had were the percentages, your brain is probably going to, in your head, look for things that might be 2 times higher with your drug versus placebo. And you're going to be looking for that. And really, when you do that, that means you're completely looking at magnitude of effect. You are not looking at strength of evidence for an imbalance. So they are very different things. So here's an example of 2 different preferred terms where they have the exact same odds ratio, right? They're about 1.5 times higher with your new drug versus placebo, but your strength of evidence is very different, right? The first one, the more common event, is much stronger evidence for an imbalance. The other one, where it's a less common event, the strength of evidence isn't as much, but the magnitude of effect is the same. So understanding that strength of evidence and magnitude effect are not the same, and some of us actually believe that knowing both of those things, right, both of those things are helpful when trying to decide what's an adverse drug reaction. So here's an example where we do think where both magnitude of effect and strength of evidence is helpful. This particular plot is not currently in our FDA'S AE white paper, but maybe it will be in the next version because some of us really like this plot. This is a volcano plot, and it actually does show the data, all of your data, all in one plot, right? So instead of pages and pages of a treatment emergent table, here's another way to look at your event data. The forest plot is another way. This way, is a way where it shows both magnitude of effect and strength of evidence. So your odds ratios and your p-values. And then what happens is everything that deserves the majority of your attention will fall into that upper right quadrant. So this is a very nice display. It's not that great when you're stuck in the static world, but there's a lot of work going on right now to make an interactive version of this display. And when we are able to make this as an interactive version, it becomes way more useful. It is awkward in the static world just because you have a lot of dots. You can't always label your PTs. And of course, if you can't hover over a dot and you don't know what these PTs are. So this is an example where we don't recommend it now if you're, because we're still very much in a static display figure world. But the minute we are able to share and create interactive displays, then all of a sudden this display might be a really nice choice. Okay, another frequently asked question is, how do you handle events occurring after stopping study drug? We have a nice section on this in the FDA'S AE white paper, and we didn't necessarily create a position on it, but we've included a whole lot of guiding principles. And part of why it's hard to create a standard position on this, because there's so many things that can go into this decision, and the design matters, right? Whether you have an extension period between your treatment period and your follow-up period matters. Whether you allow rescue meds matter, right? So there's a whole lot of things that go into the best way for how to handle events occurring after stopping study drugs. So, and there's also, not only do we have variation in design, we also have variation in opinions, right? So you have different opinions, you have different designs, and all of this matters. And so I encourage you to read that section in the AE white paper. And hopefully we'll continue as an industry to evolve on this and maybe get to a little bit more consistency on how we handle this. But generally speaking, right now we just have guiding principles that are important to consider when trying to define time. Another frequently asked question is, for studies and integrated data, should we summarize TEAAs for the follow-up period by itself? And the answer to this is generally no. We cannot think of a purpose for this. Again, it's when you do something, it's important to think, what would it be used for and why would we use it? Okay, so the follow-up data is usually there to let the drug kind of get out of the system, and we might have additional events that could be caused by the drug while it's still in the system, right, or still in the body. And so we want to know what those events are. But just showing the events during a follow-up phase all by itself has really no purpose. That's why we say for our uncontrolled data, if you look at all time while they're on drug or after, that now includes those events in that summary and then helps you more easily look for rare events. But a summary for follow-up data all by itself isn't attached to a purpose. So somebody could say, well, isn't that great data to look at withdrawal effects, right? So if you have a drug that you have concerns with withdrawal effects, yes, it is important to do analyses of that. And yes, that follow-up data is going to be really helpful. But you would define it differently. You wouldn't just look at the follow-up phase, right? So when you look at withdrawal effects, it's important to use your dose data. You got to look at when the patients actually got off dose, not when they happened to be in the follow-up phase, right? So some people could be off drug well before getting to the follow-up phase. They could have withdrawal effects during that time. And if you just summarize the follow-up period, you wouldn't get those events. You're missing some of the most important events. So it's a terrible way to look at withdrawal effects. It's not a good way to look for signals, right? So really, we do not believe there is a purpose for looking at follow-up data by itself. Okay, another common question is, why don't we have exposure-adjusted incidence rates in our standard treatment emergent adverse event table? In most cases, the idea is that in most cases, it's really just not needed. Little n, big N percent, study size adjusted percents are usually just fine. However, there could be cases where that's not true, right? So certainly if you have differing observational time, within studies, you might need to look at alternative methods. It's okay that you have different observational times between treatments, right? You could have one study that has a 12-week treatment period, another study that has a 20-week treatment period, it's okay to pool those. That's what stratification does for you, right? Because it looks for differences within studies first and then pools it. The key to when percentages, when they don't work, is that within a study that you have differential observation times between treatment and your control, and then that's when the percentage isn't going to work well for you, right? So a lot of this, there are a lot of common pitfalls or incorrect thinking about some of these, right? So people think that exposure adjustment is the complete solution for taking care of differences in observation time. Like, so if we have one study in our integrated analysis set that has different time than another study, well, then that means we need to use exposure adjustment. That's not true, right? Stratification allows for that to not be necessary. And there's also an underappreciation that exposure adjustment actually doesn't work well for events that occur early, right? So when you adjust for time, sometimes you lose your signal on those events that occur early. So it's not a great method for detecting, and a lot of our ADRs are going to occur early, right? So it's not a great method. It could wash out some potential treatment differences. And then it's kind of also a common pitfall that and I already covered this in the definition, that some people use all exposure time, instead of stopping to when the event occurred. And that would be an incorrect way of doing that. Now, again, if it's a rare event, it's probably not as big a deal, but for more common events, that could be a pretty big deal. Another FAQ is, why didn't you include a summary of adverse events considered related by the investigator, right? So if you saw that recommended list of analyses, this one was not there. So why is that? So it is in our FUSE AE white paper. We did talk about this and have a section on this. And the idea is that it's not really helpful, right? So most people believe it is not very helpful to help us identify events that could be ADRs, right? So the idea in the clinical review template, the FDA 2010 clinical reviewer template talks about this and does a good job talking about this, right? So the idea is that the investigator relatedness assessment is likely heavily dependent on what's in the investigator brochure, right? So because that's dependent on that, or they might consider it related if it's in the IB, it's not really helping us assess whether it's an ADR of the drug. So it's not very useful. So if it's not very useful, why are we including tables? So it is in the recommendations to stop. It's part of predominant practice. The recommendation is to no longer have it be part of predominant practice, and we do recommend that it is not a table we create any longer. Now, that's distinct from its usefulness for individual case review, right? So when a medical person is reviewing individual cases, that information could be useful, right? But the summary table has not had any value, is deemed to not have much value. Now, in fact, there's actually a group, there have been groups in the past suggesting we don't even collect this for non-serious events. And in our FUSE AE white paper, we actually say we concur with those people. We actually agree with this suggestion that we stop collecting relatedness for non-serious events. And so that's going to continue to be discussed. We do have a FUSE project in the new Safety Analytics Working Group on AE collection, and this will be discussed in that project team. Another frequently asked question is, what metric is best, right? So I've made reference to risk difference, odds ratio, risk ratio, so which one is best? And usually, I mean, there are other choices, but usually those are the three that come up. So the risk magnitude of effect, like odds ratios or risk ratios, are very helpful, and they're probably more helpful than a risk difference when trying to find those things that deserve further scrutiny for ADR determination. The risk difference is more helpful to understand the impact on the population, like how many patients might be impacted by this event. So there's slightly different purposes and meaning behind them. A lot of people wonder why we even consider odds ratios, right? Why wouldn't we just stick with risk ratio? Well, the odds ratio actually does have some benefits over the risk ratio, just have better mathematical properties. And there's some examples on the slide, but we also have a discussion on this in the FDA'S AE white paper, so I encourage you to read it and get more information. But they all kind of have a purpose. There's the pros and cons of each one. Of course, as we move toward interactive displays, we're not in a position to have to pick one. We actually can include the choice so that the user can pick which metric they would like to look at. Another frequently asked question is, why do some studies use subjective severity levels, like mild, moderate, severe, when we can use the CTC objective levels? So it's quite, our understanding, it's quite common, to use CTC severity levels for, say, oncology studies or other populations that are somewhat severe. But a lot of studies don't do that. They just have subjective, mild, moderate, severe. So this is another thing that we have a nice paragraph on this in the FDA'S AE white paper. But generally speaking, we think that, for the less severe populations, using a subjective, mild, moderate, severe works just fine. We don't see a reason to, create very objective levels that might require queries and, follow to make sure that the right assignment was made. We do think mild, moderate, severe works quite well. I assume this is going to be discussed. Like I've already mentioned, there is a project looking at AE collection, and I bet this comes up for discussion again in the context of that project team. Okay, let's get to adverse event interpretation now. So one thing that we do see a lot that we think we could probably discontinue this practice is defining a particular analysis as primary, right? So this is different than efficacy. So unlike efficacy, it's really not necessary to define a primary safety analysis set, right? So all of the data is important, right? And placebo-controlled data tends to be more important for the more common events, right? But our uncontrolled data and individual case reviews tend to be more important for the serious events, right? So one thing might be more useful in one setting, another analysis set might be more useful in another for other types of events. So we really don't need to be defining a primary analysis set. The other thing that is a common pitfall, and a lot of this is also because of just the way our templates are made, is to have so much focus on common events, right? So I already alluded to this. Why do we care so much about a headache that occurs at 20% and maybe 20% for placebo, or maybe it's 20% with drug and 19% with placebo, so a little less. But why talk about common events, and why spend a lot of time talking about common events? Really, it's in the templates. Maybe we have to put something there, but move on. We don't need to talk about them as much. Really, we should be talking about events that are noteworthy based on clinical judgment, or if they have a strong evidence for an imbalance or a high magnitude of effect. In our recommendations are that is the focus of any kind of write-up or interpretation of the data, is to focus on the noteworthy ones based on clinical judgment, imbalance, magnitude of effect, and less emphasis on common. So these we kind of already discussed a little bit, so it's so important to be aware of splitting and lumping because we can miss signals. And when we talk about events or we communicate events like in a label, if we communicate an event in a label and the data's been split, right? So think of abdominal pain. There's also abdominal pain, there's abdominal pain upper and abdominal pain lower, right? So if in your label you just give the percentage for abdominal pain and don't group it together with the other ones, that's probably not a good thing, right? You probably want to group some of these events. So splitting is not good, but lumping is also something to be aware of, right? So there are some PTs that are pretty broad, or groups of PTs that are broad. And if we're too broad, that could be not good either, right? So when it comes to both signal detection and signal communication, this is some of the most tricky part of analysis planning, is how to deal with splitting and lumping, both from a signal detection perspective and a communication perspective, right? So when we communicate ADRs, we want to make sure we communicate, put together the exact PTs in which should make up the communication. It is key that a lot of this is reviewed during trial level safety reviews so that these events are going to the appropriate PT, and so it's really helpful that all of that is monitored throughout the conduct of a study, that certain events actually do have enough of a description, right? The description is detailed enough so that it then maps to an appropriate preferred term. Okay, now let's move to labs. So one thing about labs is that the FDA'S white papers, they were published in 2013 and 2015, and we are due for an update. And we have a FDA'S project team working on updating the recommendations. So to some degree, our list is going to be outdated soon, but it's still worth talking about because a lot of the concepts will remain the same. So the current list is the recommendations are to look for shifts, right? You should look for shifts from normal high to low, normal low to high, right? So you're looking at shifts in your data. We also recommend box plots and scatter plots, right? So box plots are really nice for lab data. It actually can show mean, median, outliers, whiskers, right? So it's a very nice way to look at lab data. And scatter plots are also a nice way to look at lab data as well. It provides a nice way to look for those extreme values, like anyone who changed in an extreme manner. And even our recommendations for labs are currently a pretty robust package, but one thing that's always true in our recommendations is that just because it's recommended to do doesn't necessarily mean it has to go in the study report or the submission, right? So even if you do some analyses, it doesn't necessarily need to go in the submission unless it helps with the discussion. And also, it also doesn't mean it has to be done with a static display. Some of this can be done, especially scatter plots, very well suited to be done with interactive tools. Now, if something interesting comes up with that, we're not in a position necessarily for being able to share that in a submission. So we would need, if we could discover it, do it with an interactive tool. And if something is interesting, you might have to put that, create a static version of that or export a version of your interactive tool. But just because it's recommended doesn't mean it has to be static and doesn't mean it has to be in the submission. So the rationale is very similar to adverse events, right? So shifts are looking for imbalances with placebo, right? And scatter plots are looking for those outliers, right? And box plots looking for just the general trend over time or looking for changes to minimum or changes to maximum, right? So so in those cases, it's also looking for imbalances with placebo. So one common pitfall is considering that change to last observation is at all helpful for signal detection, right? And we see this a lot and maybe it is just part of predominant practice, but this is another example of something that is part of predominant practice that we would like to change. However, we kind of have it in the recommendations because we're just too scared that if it's not included in your safety package, somebody is going to ask for it, somebody's going to expect it. So while we're in this transition to try to educate people on how it doesn't really help, we might need to still do it just so you don't create a situation where you have to, create it as part of a regulatory response. But generally speaking, it really doesn't have a role, right? So it's not good for signal detection. We really like changes to minimum or changes to maximum or changes over time, right? So if a lab increases during treatment, but say it's transient and decreases by the time you get to the last observation, well, you're not going to find that by looking at change to last, but it's still it could very well be an ADR that needs to be communicated in the label, right? So missing those would not be a good thing. We need to find those, right? So last observation doesn't have much purpose. It's also a terrible one for risk communication purposes, right? So I'll show an example of that in a bit, but let's go through some other common pitfalls, right? So one common pitfall is, the first one is more of a collection issue, right? So sometimes we've seen issues that the sites don't realize the importance that at that baseline visit, it's really important to have that lab draw before treatment is given. So if treatment is given at the site, like an injection, it's important that that lab draw occurs before the treatment, right? And that has to be emphasized at startup meetings. We have seen issues with this. Another one is creating summaries for all labs in your database, right? It's really easy for a programmer set up their box plot, set up their shifts to high-low, and just run it through your entire lab database, right? And that has created a whole lot of errors, right? So some labs are there just because it happened to be collected for some patients, not per protocol, right? So those were never intended to be summarized. It was intended for that particular patient's follow-up care, right? So then they end up in a summary table with maybe 1 or 2 patients and just causes some confusion. So that's a common pitfall. And then another comment, when you do that, just run analyses through your entire lab database. You'll end up with summaries for labs that were collected in a reflex manner. And what we mean by reflex manner is you only collect that if something else occurs, right? So if you have one lab and you saw something and then that made it, other values to be collected, that's a reflex manner. So those, when you try to do a group level summary, is very misleading and not very useful at all, and gets very confusing, right? Because there's not that many patients, and it's only the patients who have a problem, right? So sometimes you end up with really high percentages of a small sample that have a problem, and it just was never intended to be analyzed anyway at the group level. It was only there to look at for individual case reviews or for that individual's follow-up care. So there's a lot of things to think about for your lab analyses. So a lot of lessons learned. And so this does take, lab analyses actually take a lot of time to plan for correctly and actually review the table figures and listings, make sure they were done correctly. It actually is a fair amount of time to make sure everything was planned appropriately for labs. So in your lab planning for your integrated statistical analysis plan, your ISAP, your PSAP, or whatever you call it, ASAP, it's very clear, it's important to be clear which labs are intended to be analyzed, and only analyze those, right? You don't want to analyze all this peripheral lab data that's only going to confuse matters. Some other lab FAQ. So why don't you recommend the shift table, right? Because this is recommended for individual studies, and this is the one that has low, normal, high missing at baseline versus low, normal, high missing post-baseline. We really do like, a lot of people like that shift table for individual studies, although scatter plots usually have some benefits over that. But in the integrated world, it's really, we don't really know how to create a similar display that appropriately adjusts for study, right? How to stratify by study in that type of display. So right now, it's just not recommended because we don't necessarily have a good method to make sure you're not being misled or being, have a lack of stratification causing an issue, a paradox. Okay, another frequently asked question is, why are treatment emergent high-low summaries based on thresholds, right, as opposed to changes, right? So I think conceptually, a case could be made that we should look at changes instead of whether you're above or below a threshold. I think a case absolutely can be made for that. But the current problem we have right now is they're really not available. Like, what would we use, right? So maybe that is a future project where having meaningful changes for each lab be established. And if that's established, that might actually be more meaningful than whether you are above or below a particular threshold. That being said, I think most medical people do like to think in terms of thresholds. They like to think, if somebody's above or below this certain thing, that's when I'm going to start to worry. So it's really not clear whether we would switch to changes if we actually had meaningful change thresholds. But this certainly does come up. I'm sure this will come up again as we continue version 2 of the lab's white paper, as there's an ongoing project to look at that. So this does come up and is a frequent question. Another frequent question is, why do we have to worry about conventional units? Hasn't the research community aligned on the SI, standard international units? Why do we oftentimes have to look at both units? And usually it's the statisticians who ask this, right? They're the ones who are saying, why do we, have to make 2 sets of tables, or why do we have to provide 2 sets of units? Why do we have this in our data, right? So most medical people probably don't ask this question, but it does come up, right? And I think, analysis planning would absolutely be so much easier if we could align on a unit, right? It would simplify our analysis planning for labs tremendously. However, we're not there yet. Hopefully we will be there someday, but we are not there yet, right? So that we absolutely need to accommodate the people who are interpreting the data to make sure it's in the units that they feel comfortable with, right? So there is a statement made by the FDA on the topic, and it basically says what I just said. They're saying, yes, we know we would like to move toward standard units, but our community, still might want to see conventional units. If you want to just pick one unit, this becomes a discussion you can have with your particular reviewer. So feel free to have these discussions with your regulator representative and see what they might feel comfortable with. So unfortunately, we are still in this world where we might have to allow for both units or have some data provided in both units, or we do have recommendations where the same display can have both units on a legend. So you're not actually creating two different displays. You might be able to handle both units in a legend. And we do have examples of that in the white paper. Okay, another question is, should we do exposure adjusted summaries for labs, right? So there are cases where we do it for events. So why would we not do it for labs? This gets really tricky, right? So unlike adverse events, lab or abnormalities can only occur when you actually collect the lab, right? So adverse events can start and stop at any time. Lab abnormalities can only occur at certain points of time when the sample is actually collected, right? So adjusting for the number of samples might be more important than adjusting for time, right? So if we are trying to adjust for something, we might need to think in terms of samples instead of time, right? So adjusting for time doesn't completely do the intended effect. It doesn't help really adjusting for time, right? So normally your initial treatment periods, you might collect labs very frequently. And when you get to extension periods, you might start collecting them less frequently. And then that's when you stop having placebo. So if you're trying, so there's a bias there. If you adjust for time, you're creating a bias because a lot of your treatment time might have less collection than a placebo patient who might have more frequent collection. So this gets tricky. We don't have a great solution for this. All I'm saying is be aware of this, right? Be aware that adjusting for time for labs may not be doing what you think it is doing. And it's not really adjusting for time, right? Because you really need to be focusing on how often you collect labs. Okay, another frequent question is that a lot of times when there's efficacy layout data, like when lab data is an efficacy primary outcome or a key secondary outcome, a lot of times the mixed model approach, right, the MMRM approach is used to analyze the data. So why wouldn't we just do that for safety, right? So this is a common question from statisticians in particular. All right, so one is we have to remember that for efficacy, a lot of times these models are used to predict that last observation, that a particular week. And for safety, we're not interested in a particular week. We care if changes occurred at any time. We're not interested in estimating a week 24 lab change or a week 12 lab change. We're not interested in that. We're interested in any time that a change can occur. So that's one key thing, but these models can still be used for that. So if we were to use a model, we would be looking at an average over time instead of a particular time point, which can be done. But we do think that it does. Lab data can not always behave right and have a lot of interesting things. So you might run into some convergence problems, and we're just not sure all of that is worth it for labs, right? So we're a little bit more leaning toward focusing on change to a maximum or change to a minimum. It's probably easier to implement and also connects us to what we are actually more interested in looking at anyway. So we tend to not recommend the MMRM analyses for labs. So interpretation, right? So mean changes are not, this is one very common pitfall, right? People like to use mean changes over time to make a characterization, right? For characterization, is it persistent or transient, right? Is it persistent or transient? A lot of people want to see mean changes over time. And if they see something go up and then it goes down, they're going to say it's transient, right? That is a common pitfall, and that is absolutely not a reliable way to look at transient and persistent. I suppose it's reliable if you're lucky enough to have nobody drop out of your trial, right? But for trials in which we have patients who drop out, it actually is a very unreliable way to assess transient persistent patterns. And here's an example of that. So this is an extreme example, right? So we have placebo in green that, it just has normal changes, all staying within kind of a range. Nobody's changing by a whole lot. And then we have a drug group in purple who has some patients that just go crazy, right? A few patients have a super high value and then they drop out. You can see you don't have any more dots after they dropped out, right? So they had a super high value and then they dropped out. All right, so let's look at group means over change, right? So the first one, you just looked at observed data. It would look like you have an increase and then it's transient. It goes down. So somebody could say, oh, it's a transient effect, right? If you look at last observation carried forward, you would see the data, you'd see the mean go up and then it just stays up. So somebody might look at that and say, hey, this is persistent. Now you can use an MMRM approach and it also kind of goes up and it goes back down. Somebody could look at this and say, okay, it's a transient effect, right? So so no matter how you look at these group means, no matter which method you look at group means, it is the incorrect interpretation. None of those interpretations are correct, right? So what is the correct interpretation? It is, we don't know. Everybody who had the high value dropped out. We don't know if it's persistent or transient, right? So there's a common pitfall to over-interpreting our group mean data. It's not reliable for persistent and transient patterns, right? You actually, these spaghetti plots, we call them, are very useful for looking at persistent and transient patterns. Now, it's not as easy as looking at a mean, but at least it's telling you the truth, right? You're looking at the data and looking at what really is going on. Okay, so other parts of lab interpretation to be aware of, right? So we do like changes to min and changes to max. However, we like that for signal detection purposes, right? Just you have differences in placebo. But actually taking that data and turning it into a meaningful statement is actually not that useful, right? So because you have just a couple baseline values, usually have a lot of post-baseline values, and you're taking mins and max across a whole lot of times in which you measured labs. So within a treatment, you will see changes, right? You're going to see changes, positive or negative changes for sure. So it's only meaningful in the context of a control and only meaningful in the context of signal detection. It absolutely is a terrible thing for signal communication, right? You would never communicate a signal by giving you an average change to min or an average change to max. It is not helpful at all for that purpose, but we do think it is helpful for signal detection purposes. Okay, let's move on to some miscellaneous topics, just a few of them, just something to be aware of when it comes to integrated safety planning. So for those who don't know, there is a new FDA type C meeting, and I don't know how new it is. Some compounds may have already had some of these or been requested to have one or offered to have one, but it is a new meeting that the FDA is offering to sponsors. It would precede the pre-NDA meeting by approximately a year, and it's all about getting alignment on your integrated analysis planning. I mean, it's a special meeting just for integrated analysis planning, right? So this is good because it gives dedicated time for this very important task. And a lot of times this was done at the pre-NDA meeting, and that's a lot of times too late, right? You've already created your integrated analysis sets. You probably already started programming. You're well on your way on implementing a whole lot of analyses. You get to the pre-NDA meeting and it's a bit too late. So having this type C meeting is, I think, a really good thing, and it is optional. But I think we would, hopefully most people would agree that it is strongly encouraged. I mean, it is your chance to have a focused time to discuss integrated planning, which can be very complex, right? It is very complex. Okay, another miscellaneous topic is about interactive tools and displays, right? So we should be leveraging interactive tools as much as possible. Safety review is one of those perfect things, right, that in which interactive tools can be so helpful, right? So they're becoming more widely available, especially within companies. We're kind of working in silos right now. Companies have interactive tools, agencies have interactive tools, and we really do need to kind of improve our crowdsourcing on this so that we're not working in silos as much. But to the extent possible, we should be leveraging any and all available tools, right, for safety review. It's really prime for interactive safety review. Also, a little bit further behind for what people are doing internally, for submissions, we should start moving away from static displays to interactive displays, right? So we're just starting to get better at this, and we're more in the pilot stage, but we do have some examples of this, and there is a FDA'S project team working on this, interactive displays for submission purposes, or interactive tools, something like that, right? So there's a whole project working on this, right? And we might need to do this in a stepwise manner. We might not want to go too fast, too soon, because we want to keep things simple, and we don't want to put any particular submission at risk because we tried to advance this too soon. But we already have examples of submissions who have included one interactive display to kind of get the ball rolling. And we do have examples of this. And the path for doing this is starting to get established. Like, how would you do this? What format the display? How does it get embedded into the structure of a submission? So a lot of this is in progress. It's already been worked on. And hopefully you stay in tune to this and start being part of this and start including interactive displays in submissions. So please help with this movement, and a lot of cross-industry work is in progress. Okay, another brief miscellaneous topic is topics about safety topics of interest, right? So we focused a whole lot of signal detection for looking for the unexpected things, right? So now when you talk about the safety topics of interest that you already know, even before you gather data, what might be of interest to you, right? Just because of the class or the population. So those are safety topics of interest. So when you have a safety topic of interest that's event-based, right, we strongly encourage the use of a standardized meta query, a system organ class, high-level group term, high-level term when possible. One lesson learned, though, is when you use a SOC, high-level group term, high-level term, you do need to be clear on whether you're including events that map in a primary manner and or a secondary manner, right? So this is a common pitfall to not be clear on this. Somebody might just say, oh, we're going to use this particular SOC. Well, some events under that SOC are mapped in a primary way, some are mapped in a secondary way. So you need to be clear on whether those are included versus excluded for your particular safety topic of interest. Now, for safety topics of interest that are expected to be rare, our recommendation is you may not even need any summary tables at all, right? So having patient profiles tailored for your special topic might be all that is needed and more helpful. Again, some of these summary tables that we do are more suited for looking for imbalances with placebo. And if you have rare events, your control data, your placebo-controlled data is not all that very helpful. What's more helpful is looking at each individual case, right? The medical group needs to look at individual case reviews. They're looking at re-challenge, de-challenge information. Can there be alternative reasons why that patient may have had an event? That's the kind of thing that's more important than a summary table, right? So some of our safety topics of interest, it might be more important to just have really good patient-level information. And we do have a white paper that's almost done, not quite, almost done. And so you'll be seeing that hopefully an announcement soon when that gets finalized and it goes through some methods that you might do for safety topics of interest. So one common pitfall is creating way too many customized lists, right? We want to use the standard list where you can. And another common pitfall is to not be clear on whether the PTs that are secondarily mapped are included versus not. So in summary, safety planning and interpretation is not easy. We do need to be trained on this, and hopefully this workshop and the previous workshop can help with that. Of course, we gave other resources that can hopefully help with that, and some of that we do consider kind of must reads. You know, if you're involved in integrated analysis planning, you really do need to educate yourself and read some of these resources. It does require expertise that you don't get from school, right? Or you don't get before you or from a previous job, right? It really is special expertise. And it is moderate to advanced expertise. It's not easy to look at safety data, especially integrated safety data. You have to educate yourself on meta-analytical methods to be involved in integrated safety data. It also requires cross-functional discussion. It's not a particular function that needs to be educated, right? Everybody, the cross-functional team needs to be educated so that we can all participate in discussions for integrated analysis planning. And general guidance doesn't always apply. A lot of times there are unique features of a particular clinical program or a particular drug or a particular design that makes some of the things that we normally do not apply. So that's another reason why it takes moderate to advanced scientific thinking. You need to know when. You need to think about whether or not what's normally done is going to work in your situation. And always think about the purpose of the analysis, right, when you're thinking about some of these general analyses that are done. So in summary, get engaged, and we welcome anybody who wants to join our new safety analytics working group. We're going to be continuing some FDA'S white papers. We're going to continue our educational efforts. We really want to create a very solid educational library, and we welcome any help to build our educational library and any help to either co-write or to review our white papers. So thank you. And again, this is recorded and it will be publicly available on the FDA'S deliverables site, and please share it with your colleagues. Again, we tried really hard to make this be appropriate for a cross-functional audience, so please share this with your colleagues and welcome any comments. And unfortunately, we didn't, we don't have an interaction with this, but please let me know if you have any questions, and we will, certainly talk about a lot of these issues over time as we continue to work on FDA'S white papers and we update white papers. A lot of these topics will be continued to be discussed over time. So thank you for your attention, and hope you get involved in the Safety Analytics Working Group. Thank you.